So here we'll discuss oral kinetics, IV delivery, first pass effect, and really take the distribution idea and apply them to real dosing patterns. So we'll compare repeated oral dosing to IV delivery, and then talk about the first pass effect and why something as simple as taking a medication with breakfast can alter a body's response to the medication. Now, a single oral dose will give you a peak plasma concentration. This is what we see in that panel on the upper right. The drug concentration then continually declines, and repeated dosing results in oscillations in plasma concentration. So, repeated dosing has a significant impact on maintaining the therapeutic range. So, this slide shows the general kinetics of an oral dose over time. The single dose gives you a rise, a peak, and a decline. If you repeat the dose at the right interval, then you can keep the concentration within that therapeutic range. So that's the whole point of repeated dosing. We're not just giving more drug randomly, but we're trying to maintain useful concentration over time without dropping below the effective range or climbing into a toxic dose. This is why questions about can I take 2 pills at once or what if I miss a dose, right? These all come into play with when we're understanding some of the timing. So timing the additional doses so that we don't ever fall below the therapeutic dose. This is ideal. Making sure that we don't take too much of the medication where we're rising into that level of toxicity or perhaps that lethal realm. So a follow-up, or second dose may be necessary to achieve or maintain that long term, until that initial dose has worn off. So we'll keep in mind some of the strategies that are used by prescribing physicians to make sure that we maintain in that therapeutic range. So I'll present you with another practical patient question. If an antibiotic is prescribed 4 times per day, can the patient just take 2 pills twice per day instead? It's a reasonable question. Here's our athlete asking that. And usually that's not a good idea or a substitute because the spacing matters. The goal is not simply the total number of pills per day. Otherwise, we just take all the pills in the morning and call it good. But the goal is to keep the drug in a therapeutic range for long enough of the day to work effectively. If the interval is widened too much, the concentration may fall below the therapeutic range, below that threshold. So our athlete asking, I have to take this antibiotic 4 times a day, but I'm having trouble remembering to take it. Can I just take 2 of them twice a day? Well, maybe. It really depends on the drug and what we're treating. That strategy may work for urinary infections, but it may not be ideal for tissues with poor drug penetration or perfusion, low perfusion tissues like cartilage. Higher doses could also raise side effect risk. And so this is why it might be a challenge for a patient who is having those trouble not to take too many at once, but rather use the prescribed dosing. If it's an infected ear piercing, let's say, this may not be a very good idea because cartilage gets very low drug concentration. So it may be necessary to give that drug over low doses over the period of 4 doses per day. Other drugs can have serious central nervous system side effects, especially in older patients if the blood levels get too high. So taking too much of a drug instead of the 3 or 4 doses per day can be a problem. So spacing out the drug, this is necessary from the standpoint of the provider because they know we're trying to maintain therapeutic range, we're trying to maintain the amount that's getting to the tissue, and we want to avoid getting below the therapeutic range, but we also want to avoid, stretching into that area of toxic concentrations. Let's look at an intravenous injection. This is going to get the drug into the circulation immediately. That means the concentration is going to be highest right away. This is an injection, a single dose. And from there, the body begins to distribute and eliminate the drug. This is why IV administration can create very rapid onset of the intended effect. But it also means the time course looks very different from an oral administration. See, oral administration, absorption is slower, and concentration rises more gradually. It has to go through the stomach, has to go through the extrahepatic portal system. On the figure, you see that the same medication is administered here, but taken in different doses. Now, in this case, the rate of metabolism may be faster for the higher dose. Just look at the time course for zero drug. We take a larger 100 millimeter or 100 milligram injection, and we see that the end time course 0 is the same for both the 50 and the 100 injection. This is an example of first order kinetics. If we look at plasma concentration, we see it rises during infusion. Now, infusion is not a single dose, but rather consistent dosing over a period of time. It maintains steady state until the dosing is stopped or we eliminate the drug. So faster infusions may get more drugs on board, but faster infusion may not change the time to achieve steady state. In both of these instances, fast infusion and slow infusion, you see that the time to reach steady state is the same. So intravenous injections or infusions are different from IV bolus injections because the goal is usually, in this case, to maintain concentration over a period of time. Instead of delivering the entire dose at once, the drug is infused at a rate that's intended to match the desired therapeutic effect. A faster infusion may get the drug into the system faster, as we talked about, but maintaining the right concentration over time, that's the larger objective. And in this case, we achieve steady state with a slow or the fast infusion. So infusions are intended to maintain the certain plasma concentration, IV drip rate to allow the drug to be continuously administered to maintain a dosage within a therapeutic range. And all of these considerations pertaining to the correct dose for the patient to get the correct plasma concentration to initiate the overall response. Let's talk about the first pass effect. Here we're going to look at a number of different things, but ultimately looking at the dose of the medication passing through the portal circulation, reducing the amount of drug before it reaches the systemic circulation. In other words, we're now going to talk about metabolizing the drug. There are also other forms of delivery, but let's look at the first pass effect here, which applies to oral drugs because the absorbed drug reaches the liver before much of that drug is going to actually reach the systemic circulation. In other words, we consume it via mouth, into the stomach, into the small intestine, and ultimately the liver may metabolize some of that drug right away, which reduces the amount of active drug that's going to reach the rest of the body. In some cases, the metabolism can activate the drug, as with codeine being converted into morphine. So this is a necessary first pass effect in order to have a viable, usable form of pain relief. But in many cases, the first pass effect reduces availability and has to be considered when choosing the dose and the route. First pass effect typically only applies to drugs orally because IV or intravenous infusion bypasses the stomach altogether. Bypasses the intestinal tract, goes right into the circulation. Now, sometimes going through the liver is necessary. That's what we talked about with codeine converted into morphine. But also keep in mind that the liver has a bunch of enzymes that start metabolizing the drug, in most cases deactivating the drug. Therefore, the dose of the drug that we give has to take into account how much of the oral drug is going to be metabolized before the drug makes its way into the blood. In this manner, we're looking at the liver being considered a detoxifying organ to help get rid of the drug. And that's what we see in this figure, where the drug is taken via mouth, enters the GI tract, enters portal circulation. Now the first pass effect in the liver, finally, whatever's remaining is bioavailable in the systemic circulation. And this slide's a great reminder that counseling instructions also matter. Let's take an example here. If thyroid hormone is prescribed to be taken before food, that timing is part of the treatment. Food changes the digestive environment. It changes contact time. It changes the effectiveness of the absorption for certain medications. So when a patient wants to simplify the routine by taking the medication with breakfast, the answer could be no, because the timing changes the drug's performance. So the core point here is that the route, the timing, the repeated dosing all shape the drug availability. A medication schedule is part of the treatment, not just an afterthought attached to the prescription. See, food in the stomach increases, in some cases, the enzymes present. And these may cause an increased drug metabolism and make it to be less effective or make less to be available in the blood. So our example here where the doctor has put the athlete on the thyroid hormone, said I need to take it 1 to 2 hours before eating in the morning. I don't like waking up early. Can't I just take it with breakfast? Our provider here says no. Taking it with food can severely reduce absorption. It should be taken on an empty stomach before breakfast. So this all highlights the importance of understanding the route of administration, the timing, the dosing. All of these elements are important to follow prescribing recommendations. If there's any questions on this, return back to the prescriber, in this case possibly the physician or pharmacist, to confirm whether or not you can change the dosing strategies.